All right. So for everyone that's logged on, I can see everyone so far. We have about 30 people. We have a few more to log in here. So for you guys that are here, you're at amniotic membranes for contact lens complications and anterior segment pathology. We're just going to give everyone a few more seconds or maybe a minute to log on, and we'll get started. Maybe we need to do a polling question while everyone's kind of logging on. We'll do that for the next one.
There you go.
Give about another, still kind of in the 30s. There we go. It's starting to creep up now. So, all right. So I'll just some housekeeping, and while everyone's kind of getting logged on here, during the presentation, well, tonight we have a special guest here. We have Roger Kennedy from Biotissue. He's going to do a little intro before we start the CE program. Thanks to Arbo and Cope for allowing that to happen for these webinars. There'll be some handouts whenever I start the my part, the CE part of it. So we'll get those launched. So be aware of handouts. There'll be the full presentation and the 6 slides per page. We'll have some polling questions that helps with the live and interactive part that allows us to get credit for these. This course is being recorded, just so everyone knows. A replay will be sent tomorrow in about 14 hours after the presentation ends. It takes some time to process, and it'll be an automatic link just generated, just like you did whenever you registered for the program. There will be a survey sent probably around 8 or 9 o'clock tonight. So for these programs, in the regulatory process, we do need to have as many surveys as possible. So please answer the survey tonight, and or tomorrow there'll be another link for it in the replay, but please do the survey for us. Webinar Jam is a cloud-based system, so we've tried making it clear in the registration process that really if you're having issues and there's a reconnect button, you don't have to hit it unless you're having problems. The key is decreasing your bandwidth at home. So if you're streaming something else on your computer right now, that's going to hurt the bandwidth. Any Wi-Fi services, Ring doorbells or children or spouses streaming movies, that really slows things down. People gaming in the house, that will decrease the bandwidth, and that's where we run into a lot of issues when we do these webinars. There is a chat room feature that you can ask your questions. So I think that's pretty much the housekeeping. Joe, do you want to take care of our special guest here tonight?
Oh, yes. Of course, we were just introduced to the housekeeping by Greg Caldwell. And of course, Greg is in Pennsylvania, and he is in a medically oriented optometric practice and has a lot of experience using amniotic membranes, and this is amniotic membranes for contact lens complications and anterior segment pathologies. And Greg is my partner in optometric education consultants, and it is our goal to bring either live in some fashion or manner clinically pertinent education that helps optometrists meet the requirements and advance their practice. But as Greg said, we have a special guest, Mr. Roger Kennedy. He's Director of Marketing for Biotissue. He is a South Florida native. He works in Miami and lives in the Fort Lauderdale area. And he's going to have a little bit of a few words to say before our CE begins. So with that, Roger, please take over and welcome.
Thank you, everybody. Yeah, I just want to take just a quick second to thank everybody for having me on today. I'll try to be on time and as expeditious as possible, but really excited to share information about Biotissue and Procura, and I think it's going to be really helpful moving forward, especially going into the next phase of the webinar here. So that I'm going to start my presentation, and this presentation is going to be on ProCara. The agenda for today is going to be the scientific platform of cryopreserved amniotic membrane, also referred to as CAM, ProCara's clinical applications, and then the reimbursement and patient access landscape. So taking a step back with biotissue, something we really pride ourselves on is the fact that we have validated and evidence-based technology. Biotissue's history is in research and innovation. As you can see by the bullets mentioned here, are second to none. We have 30 years of NIH-funded scientific research, over 350 peer-reviewed publications, over 300,000 transplants, and over 120,000 ProCara placements. This really gives us the confidence that one, that we're the market leader, and two, that we've kind of seen or done everything that we know amniotic membrane to be useful for. And then with all that being said, we're still constantly learning new ways as far as learning what regenerative medicine can be used for in different aspects, not just within the eye, but also around the body in general. So it's something that we're really proud of, and you can take comfort in knowing that if you do try something like ProCara, that there's definitely, it's not a new toy. It's something that's been used for quite some time and has had some success for quite some time. So what cryopreserved amniotic membrane does, it features a regenerative platform that retains natural growth factors, cytokines, and key proteins with a complex extracellular matrix. So the cryopreserved amniotic membrane, also ProCara, it's the only amniotic membrane recognized by the FDA for having therapeutic properties. That's a big differentiator for us. The FDA properties, the therapeutic properties that were FDA designated, is anti-inflammation, anti-scarring, and being anti-angiogenic. Here are the SKUs of ProCara. There are 4 SKUs. I'll kind of go from left to right here. The first one is ProCara, also known as ProCara Classic or ProCara 16. It was the original ProCara. You can see that it has a symblepharon ring around it. And because it was the original ProCara, we had quite a bit of success with it. We wanted to make some enhancements with ProCara. We continually want to improve our product. And that kind of moved us along to the second one, which is ProCara Slim, which is literally a sheet of amniotic membrane on an ophthalmic conformer, just like the original ProCara, except you can see the profile of the ring is a lot smaller, a lot thinner, and a lot more comfortable at that matter. So, you know, for your purposes in using or want to choose which ProCara to use, I can say that 90% of the time ProCara Slim is being used. And then the other products are used when appropriate, depending on the situation. So I know with the original ProCara, some people never have an issue with it, so they never change. Sometimes things like droopy eyelids, or there's just certain conditions that ProCara would be better for, ProCara Classic, but most of the time ProCara Slim is going to be a better option because it's more comfortable. That's moving along to, if we move along to the third one, it's ProCara Plus, which is exactly the same product as the original ProCara. It has that thicker symblepharon ring, and it also features a double layer of amniotic membrane. So for these cases, or for this product, you really want to use them on more severe cases, things like chemical burns, Sjogren's disease, Stevens-Johnson's. It features that symblepharon ring to keep an eyelid margin between the cornea and the eyelid, as well as that dual layer of amniotic membrane allows for more therapeutic benefits. Last is ProCara Clear. So ProCara Clear is actually the same exact thing as ProCara Slim, except with a 6mm aperture in the middle of it. So if you have a patient that needs amniotic membrane, but maybe it's a monocular patient, or a patient where visual acuity is a primary concern for them, or just a big concern for them, assuming that ProCara Clear does center well, and there is that caveat that it needs to center well, the patient can maintain visual acuity while receiving the benefits of amniotic membrane. I'll just touch on the bottom two. It's the same thing as the top. It's the cryopreserved amniotic membrane, except it's not in a ring. These are mostly used for surgical procedures, both in the amniotic membrane, which is the amniograft product on the bottom left, and on the bottom right is the umbilical cord product, also used in surgery. It's used by ophthalmologists as well as a lot of oculoplastics use AmnioGuard as well. So kind of going into healing, and there's different healing priorities after birth. So looking at the difference between fetal healing and adult healing, you know, when you take a look at the fetus and the fetal environment, the priority is to guide development, right? So you're trying to grow this baby, you're trying to maintain pregnancy, follow the genetic path, and really the big concern is tissue generation or regeneration if needed. That's the main goal of a fetus and in that fetal environment. And that's a bit opposed to what goes on in the adult environment. And that's really after birth when we're saying adult. The priority there is to survive any assault that the world around us gives. So that's why we respond the way we respond, and the fact that when an assault is given on our body, we do everything we can to prevent infection, stop bleeding. We create a barrier, and that inflammation process oftentimes creates scar tissue. And the reason for it is because, you know, when something happens when we're an adult, the fire alarms go off, we want to fix it as soon as possible. In the fetal environment, they always have that long-term goal of, well, at the end of the day, I need this baby to grow, so they can be more systematic in basically the healing whenever things go awry. So the biological properties of placental tissue can be preserved and translated to adult environment via cryopreservation. And that's kind of the magic of amniotic membrane, is the fact that you can take this amniotic membrane, put it into an adult environment, and it will heal as if it were in a fetal environment. So the way this is done, it's done because of a key complex responsible for the therapeutic benefits. So a big difference between a lot of amniotic membranes is the fact that there's a presence, most amniotic membranes, if not all of them, have that presence of growth factors and cytokines, but not a lot of them have the presence of this complex right here, heavy chain hyaluronic acid pentraxin 3, also known as HCHA PTX3. The founder of our company, Dr. Sang, he actually got that FDA designation for anti-inflammation, anti-scarring, anti-angiogenic. And when he got that designation, he wanted to keep persisting his studies and really figure out why the therapeutics are happening. It took him about 20 years, or excuse me, it took him about 10 years, excuse me, to figure out what specific complex, what specific hormone or protein is happening that's causing this effect. And he's finally isolated it to the HCHA PTX3, which is found in the gestational stage of life, mesenchymal cells as well, stem cells as well, but they're dormant in your body. So what does HCHA PTX3 do? It orchestrates healing, and it does it through a variety of ways. So at the end of the day, it does suppress inflammation, it does prevent scarring, and ultimately promotes regenerative healing. And the question of, yeah, but how exactly does it happen? This is the mechanism of action of what HCHA PTX3 is doing. So it's facilitating neutrophil apoptosis, polarizing M1, which are pro-inflammatory macrophages, to anti-inflammatory M2 macrophages, suppressing lymphocytes, specifically Th1 and Th17. For preventing scarring, it's preventing myofibroblast differentiation, and then reprogramming it into progenitor cells. And then lastly, it supports and augments mesenchymal stem cells and maintains stem cell quiescence. So further studies were done on this just to validate that point that the founder of the company, BioTissue, has kind of figured out. So if you look at this study here, it's by the JWC Journal of Wound Care. Cryopreservation maintains the quantity, quality, and activity of the biosignaling factors found in fresh amnion, HCHA PTX3. And the reason why this study is so important is because it also looked at dehydrated amniotic membranes. And when you looked at dehydrated amniotic membranes, it showed a compromise in structural integrity of the tissue, and then results in a lack of active biosignaling factors. You can see here assays looking for the HCHA PTX3 in both cryopreserved and dehydrated. It's hard to tell here. This is dehydrated amniotic membrane. This is cryopreserved amniotic membrane. and you can see the presence very much happening with which high molecular weight hyaluronic acid, and not so much with dehydrated, as well as with the heavy chain being minimally present here, but very present here, and the pentraxin 3 being very present here and almost absent here. So the indications that Procura can be used for, like I said, it's good for anti-inflammation, rapid epithelialization or reepithelialization, causing minimal haze or scarring, symptom reduction, corneal nerve regeneration, and infection prevention. Where it can be used, there's a wide array of indications that it can be used for. Moderate to severe dry eye disease is very common, especially if you have some sort of central SPK, as well as persistent epithelial defects, corneal ulcers, recurrent corneal erosions, neurotrophic keratitis. Procura is appropriate for as well, and you can kind of see where it would be in the treatment protocol. Also looking at Sjogren's, TENS, chemical burns, Steven Johnson's, that's also a good placement for Procura as well. So looking at dry disease and Procura, you can see that there's a number of studies that show basically the reductions in signs and symptoms. And what's nice about it is that you see the reduction in signs and symptoms at both 1 month and persist on through 3 months. So this is after the amniotic membrane has been removed. We also showed an increase in corneal nerve density and corneal nerve sensitivity. And with that increase, patient gets a lot more feeling, and I know that's been a hot topic as far as the corneal nerve's role in dry eye disease. And this is an example of SPK being cleared up after one placement of amniotic membrane of Procura. So implementing Procura, I won't go into this too much. I'm pretty sure you're going to be getting into that into the lecture there, and it's managing expectations, making sure they know, on the first day of the insertion, so go home, rest their eyes, and basically all of the ways, like I said, the science of what's going to be happening, and you're going to be getting that anti-inflammation effect, as well as preventing scarring if there's any type of defect down to the stroma. And to kind of wrap things up and to put you at ease, if you're looking for logistics, average Medicare reimbursement is $1,458. And the level 1 CPT code was actually founded by us. We're the ones that pioneered and created the CPT code. So it's based on the placement of Procura. We continue to do everything we can by supporting lectures like this, the AOA, the AAO, BCBS, when there were some reimbursement challenges. It's something that we're really committed to because we believe in the technology. So thank you for your time. I appreciate it, Dr. Caldwell. Back to you.
We thank you. Joe, do you have any comments before we get started into the CE program?
No, my only comments is I thought the explanation was outstanding. It was a very high level understanding of that material, and we're very happy, very fortunate that Roger's able to present that. So I think now it's time to switch over to the actual CE part of our evening. And Greg, take it away.
Thank you. And again, to make it clear, the promotional part of that is ended, and we're going to start with the educational program here. And I'd like to start off with just by doing a polling question to the audience here. And the polling question is amniotic membrane. Oh, hold on, wrong one. End poll. Let's go and reset that, and let's go up to the first one. Start poll. Here we go. This is the one we wanted to see. Is amniotic membranes. How many do you do out there? Do you do at least once a month? I've never inserted an amniotic membrane. You should send these to an ophthalmologist to be done. I don't do an amniotic membrane. I do send them to an optometrist that does, or I don't do amniotic membranes and send them to an ophthalmologist. So that's the first polling question that's out there. All right, I'll end the poll. And I think the answers were being shown. So let's jump into my slides. And every time we do a presentation, we have to go over disclosures. The only one I really want to make sure I disclose is that I have spoken for BioTissue. I have no financial responsibility with BioTissue. When I do speak for them, I do receive an honorarium. Nothing's being received for them for this presentation tonight other than the opening up. And you can see all my other disclosures. With financial disclosures, I always thought it would be good to show financial obligations. Here are the obligations. Big Disney person, and so with my financial disclosures go my obligations. Now, let's jump in here. The course description is in the handout. I will launch the handout. Let me just jump and go do that now in case you guys want to have that. There are 6 slides per page and the full handout. Whichever one you want to download, it's there for you. This is being recorded, and we will put it on our YouTube page for OCT or for OEC that's out there. So Optometric Education Consultants YouTube. So there's the course description, the amniotic membrane history. Amniotic membrane has been around since 1940. Dr. Sang and Kim was using it for ocular surface reconstruction all the way back in 1995. But it's right here in 2005 that we see the single sheet retained polycarbonate in office and sutureless. So 1995 is when it was for ocular surface reconstruction, but the sutureless in office really kicked in 2005. So for 15 years, and you can see around 2012 is whenever the dehydrated entered the market. The key to using amniotic membranes is understanding adult wound healing. That is different than regenerative healing. And you can see here when you have a trauma on day 1, you have inflammation and proliferation and migration of macrophages and lymphocytes, and then remodeling. But typically you end up with a scar. And we deal a lot of times with the cornea, and we really don't want that cornea to scar. We want to deal more with a regenerative process where when you get damage to the tissue, you're getting a replacement of the original tissue rather than a scar. So one of the things I like to point out during these webinars is that regeneration versus repair. Regeneration is replacing the cell tissue and no scar, where repair is a scar formation or granulated tissue. So we're getting that, try to get that exact placement. And we do know that the amniotic membrane has this regenerative wound healing process. And so the question I like to ask is, where does this membrane come from? Do these guys that do amniotic membranes just kind of hang out at the hospital watching for pregnant ladies to walk in and saying, hey, looks like you're going to have a baby sometime soon. Mind if we give you $50 for your placenta? Because I'd really like to have your amniotic membrane. That's not how it happens. These are planned C-sections. And when you get into the later slides here, you'll see that it's very highly tested and regulated tissue with blood work and lots of follow-up. So it comes from a planned C-section, and they're all humans tissue. Sometimes I hear colleagues saying, well, I wonder if they use animal tissue. They do not. It's all human tissue. And when you use the amniotic membrane, the regenerative tissue responds away from that inflammation, that blood vessel growth, scarring, and rejection that can occur. So the amniotic membrane is the most inner lining of the placenta. And what I like pointing out here is there's 2 layers of this amnion, in a sense, or this amniotic membrane. It's the amnion and the chorion. And you really don't want any chorion whenever they finally decide to, make it into a product. Really, all you want is the amnion. And what I like pointing out is look at the tissue, the extracellular matrix composition. You have collagen fibers 3, 4, and 5. You have laminin, fibronectin, again, collagen, proteoglycans. You have a basement membrane, a compact layer, epithelium. Doesn't that sound kind of like the cornea? So it's kind of nice that you have these stem cell-like activity in the amniotic membrane, and that's how you start steering towards that regenerative process rather than that passive or repair. So it's really going back to this regenerative tissue healing, the anti-inflammatory, the anti-scarring, and the anti-angiogenic. And what I want to point out is the great pain suppression that these amniotic membranes have. There's just something in there that suppresses those nerve endings. Very little time do I have to use like a narcotic for a patient, or, high doses of ibuprofen and Tylenol. Sometimes you do, but a lot of times you don't. So it has a great pain suppression. So when we talk about ocular surface disease here, we're talking about keratitis is probably the number one reason where I use these in the office. Anywhere, as you're going to see, that's why we're on here tonight, from corneal infections to dry eye to a whole litany of cases here that you'll see. Conjunctivitis and blepharitis is the hallmark is inflammation under all those itis. And what we want to do is on this left side here, you see we want to control the inflammation. We want to promote healing, but we want to get exact placement of the tissue. And we're really good at doing passive healing, where we have somewhat controlled or uncontrolled inflammation, but maybe using steroids, and that can lead to more tissue damage. And then we can have ulceration and scar formation. So amniotic membranes definitely are taking it to the next higher level whenever you're having a severe trauma in your office, or a corneal insult from maybe a bacterial or even a viral keratitis, which we'll cover here shortly. So we're very good at passive healing, right? We know how to use bandage and therapeutic contact lenses, steroids and NSAIDs. But where I don't see a lot of my colleagues out there is using this dual therapy of controlling inflammation and scarless healing, and using amniotic membranes or a biological Band-Aid. And pay close attention to those words as we go through this presentation. And this here is where it all makes sense to me out there, is in this scarless fetal wound healing. You can see here that Dr. Michael Harrison shared these slides, and there was a baby at 26 weeks in utero with this large mass. They went in utero and they did the surgery. And the story kind of goes is like, hey, the surgery went well. I think the baby's going to be okay, but don't be surprised if there's this big scar when the baby is born. And the baby's born and you can see that there's no scarring. And then all of a sudden people are scratching their head and saying, okay, what's the difference between healing inside in this fetus versus when we get out and we have healing with as a child or as a fetus, different than adult or as a child? That's scarless. Something is happening, and there must be something with that amnion. And you can see here that it's been used in a different type of procedure here, healing this diabetic foot ulcer and getting this normal tissue, this regenerative tissue, or this normal tissue back. Rather than just filling this at 10 weeks with a scar, you actually get the exact placement of replacement of tissue there. So it's been used quite a bit. It's used in burn units, and obviously now we're using it for the eye. And tonight we want to learn more how to use this. And again, we've said this, I think we beat this to death here, is that we want to get away from something like this, the thinning of the cornea, maybe the haze and the fibroblast. And we want to get where we can insert a membrane and get a nice clear cornea in the office and treat these patients. So ocular surface disease challenges. Where can we use this membrane? Well, neurotrophic epithelial defects, we use them a lot in the practice. Maybe someone has had herpes zoster or even herpes simplex, and they just don't have great wound healing. They have corneal desensitized. Their cornea is desensitized, and they just can't heal And you can see here with an amniotic membrane how well this patient's cornea healed with a neurotrophic type of corneal disease. Infectious keratitis, and you can see here, we just had one during the COVID crisis here. We never really shut down. We're not in a real epidemic area, but we had a corneal ulcer, almost very similar, come in, had a central ulcer, one in the periphery, no hypopyon, but we did use an amniotic membrane to minimize that type of scarring. And pay close attention here to that this is an infectious keratitis. And ask yourself right now, because it's coming up, which amniotic membrane would you use in this type of infectious keratitis? And it's one of two answers, or maybe it's one of three answers. Is it that you can use dehydrated and cryopreserved? Is it cryopreserved or dehydrated, or is it none of the above when it comes to treating an infectious keratitis like this? And then herpes simplex. How about this for a viral? And how many times have you want to use Zirgan, and you send it to the pharmacy, and they're like, well, I can get it from the warehouse and it'll be here in 24 to 48 hours. But you can kind of see here, you got something centrally located, and you probably want to get some type of healing. So you can obviously go oral on this patient. You can do Valtrex or acyclovir, start to reverse it. And studies have shown that, it might be just as good as going topical. My rule of thumb is when it's centrally located, I'd like to go topical. If it's out in the periphery, I'm okay to go orals. But if I can't get the topicals, and a lot of times I'll place a Procara or an amniotic membrane on this to try and treat this. And you'll see why here towards a few slides why I said Procara. And during these presentations, we need to be, in a sense, fair and balanced. And you'll see why I lean that way with a little bit of scientific evidence coming up here. Filamentary keratitis. This is a very severe dry eye. And I probably have a few patients that come in about every 6 to 9 months, just severe filamentary keratitis. They're usually a rheumatologic patient, and they're just suffering from these filaments, and we are hitting them hard, on the stage 1 to 4. This is a stage 5 dry eye. And I'm able to place a membrane on their eye, and it's amazing. The shortest, I guess, that they'll come back is 6 months, and then the longest is about 9 months. But once they feel how good their eye feels, they know when this is kind of wearing off, and they'll come back in. Because remember, a lot of the time these rheumatological patients, they're autoimmune, so it's very hard to reverse this autoimmune process. And if they're not very well controlled, maybe, and even if they're on some maybe biologic that's out there, Embra and Humira, they're still not controlled. These patients know how their eye feels, and they just come in. And I've been loved doing that for these filamentary keratitis patients. They come in, we do the one eye because it's blurry. Then we bring them back about a week later, and then take the one off and put the other one on, and they're kind of good for that next 6 to 12 months that's out there. Recurrent corneal erosion. I love using it for recurrent corneal erosion. I'm going to jinx myself one of these times. I just did one about 10 days ago for recurrent corneal erosion. And you can see here there's a Wexel sponge. You can see the defect. We kind of clean up the edges, and then we use an amniotic membrane on these patients. And like I said, I'm going to jinx myself because right now I'm about 23 out of 23 where I haven't had to send them for stromal puncture or some type of PTK. I'm sure I'm going to run into a cornea that's just so diseased that it's going to have to go to more of a surgical approach. But luckily for the last 23 of them, that we were able to use amniotic membrane. So let me just kind of show you a little bit on recurrent corneal erosion. Let's see if I can get my videos to kind of pop up here. We're going to start this one here, and good, it's loading. Let's see if I can turn down the volume. Good, because there is no volume. anything to listen to. So here you're going to see, this is a patient going for PRK. And you're going to see they're going to remove the epithelium. And what I want to show you with this is look how hard the surgeon is scratching the cornea. I mean, you can see the cornea is indenting. They're really using a lot of pressure there and scraping away, because they have to get down to that anterior Bowman's to reshape, because it's a photorefractive keratectomy. And, you know, nowadays they use alcohol. It's maybe they don't scrape as much. But now let me show you a patient that went for PTK for a treatment of a recurrent corneal erosion before I was doing amniotic membranes. So here's a patient here. You can see that they've already have an abrasion from the recurrent corneal erosion. And watch how easy this epithelium comes off. And now you can see why when the patient goes to sleep at night and that back surface of the eyelid sticks to the anterior surface of the cornea, the epithelium, and it dries out and it sticks, and then maybe they go into REM type of sleep pattern, or they just stick down and they decide to wake up in the morning. You could just see how diseased that epithelium is and why that eyelid and that epithelium and why it becomes a recurrent corneal erosion. And that's why I wanted to show you that video before, someone going for PRK that doesn't have EBMD, and this is a patient that has a recurrent corneal erosion. And what we're doing with the amniotic membrane is kind of healing that basement membrane. So how I do it in the office is a lot of times there's 2 or 3 of us in the office. I work in a practice of 5 ODs. A lot of times I get them since I have the most experience. And I'll walk into the room and I'll just say, hey, look, it looks like, the doc has taken good care of you. Your erosion is all healed. The next time that you tear open, give us a call. We always keep about 5 membranes in the practice at all times down in the freezer. And I just tell them, look, the next time you tear open, we'll kind of clean up that wound, which means usually go in limbus to limbus. And that's how I've learned the power of the pain suppression. Because I remember the first one I did, I was working with my technician and literally trying to take off the loose epithelium. As you can see here, the epithelium is pretty diseased. And just by using a Wexel sponge, the epithelium came off limbus to limbus. And then we put on the membrane. The only time that they're really not limbus to limbus is when it's from trauma. If someone remembers getting poked, with a child's fingernail or some type of cardboard, usually the rest of the cornea, it's not from EBMD, it's just from a trauma. Then you just kind of work in that area and the rest of the epithelium will stick down. So we use it a lot for recurrent corneal erosions in the practice. So I'm going to go back to the slides here. And these were the 2 videos. And we use it in Salzmann nodule degeneration. Now, we really don't use it in the office for the Salzmann nodule. The Salzmann nodule usually gets removed by the surgeon in the operating room. And when they come back for their 1-day post-op, the surgeon always makes sure that we have the membrane there. And then we put the amniotic membrane on to really promote and allow that cornea to heal in a scarless type of fashion. So Salzmann nodule works really, really well. Chemical burns that's out there, we use it for chemical burns, especially the basic alkaline type of chemical burn, which we know can hit and penetrate. They work really well for chemical burns. Stem cell burnout, the title of the talk is to use it in contact lens and other anterior segment pathologies. We already talked about infectious keratitis. Some dry eye can occur from wearing contacts, some toxic keratitis maybe from solutions, and then stem cell burnout. And I want to point out, see how these clouds are here kind of wispy here in the center, not these big puffy clouds, but these kind of wispy clouds. I'm sure they have a name that's out there by meteorologists. And that's kind of what stem cell burnout looks like. And if you see stem cell burnout the first time, you'll never forget seeing it again. And the stem cells here at the limbus, they, in a sense, just get traumatized. It's, usually a silicone lens. It's a multi-purpose solution. It's up under the superior. It's usually at 12 o'clock. There's hypoxia from the eyelid, the contact lens. There's toxins from the contact lens solution. There's trauma from the eyelid, the thick contact lens. And these stem cells get traumatized. Now, I'm going to go this slide right here. This is a case of amiodarone toxicity. And what I like about amiodarone toxicity is the amiodarone kind of acts as a tracer of how the epithelium repairs. And the epithelium repairs by stem cells slowly sliding in and creating epithelial cells. And as they slide in, and then they kind of pile up on top of each other. But I like when I look at a nice big vortex whirl like this, because you can kind of see how the cornea heals. This travels a long way and this kind of travels a short way. And that's just how the cornea heals. So I love looking at amiodarone from a geeky optometric standpoint, just to see how that cornea heals. Our cornea epithelium turns over every 10 days. And I remember that because I remember whenever I went to Poland to lecture and then the volcano erupted and I got stuck a few extra days, I was teasing them because I taught an anterior segment course that I came with USA epithelium, but I'm leaving with Polish epithelium because I was there longer than 10 days. So that cornea regenerates the epithelium every 10 days. So you can kind of see in a cornea how that heals. Now, what I want to show you here is, and that's why I have that slide in here, is if this is damaged limbal cells, you can see that this bad, poorly constructed, traumatized epithelium, it's kind of wispy, it's kind of cloudy, and then it just kind of stops and clears up, just kind of how that amiodarone cornea looks. And this is probably the best picture to see it, is this is a patient with stem cell exhaustion, limbal stem cell burnout. There's a bunch of different names for them, but you can see here how it's just kind of superior staining, a little epithelial defect right here. There it is, the patient looking down. You can see some staining right at that stem cell area. And what is an amniotic membrane? It's stem cell-like activity. And this is a contact lens complication that could maybe take a year to heal, but you can really reverse it and make it a lot shorter when you use an amniotic membrane because you're healing that limbal cell. So this is one of those contact lens complications that I love using an amniotic membrane because of that stem cell-like activity from that amnion. So those were just a few things that you can use an amniotic membrane for: corneal erosion, corneal scars and opacity, dry eye, thermal and chemical burns, infectious keratitis, foreign body removal. If it's centrally located, you want to minimize the amount of scarring that could be over that pupil. So sutureless amniotic membrane, another few words that I like to point out is wound healing versus wound covering. The cryopreserved and dehydrated, those are your two major categories. And cryopreserved is wound healing, which would be the Procara, and you could see dehydrated, which is wound covering. Because if you're going to use these, make sure you understand the difference between cryopreserved and dehydrated. And there's quite a few out there that make it. And you can see I have them listed here: Ambiodisc, BioD, Eclipse, Ariel here. And, there's more dehydrated. There's only one cryopreserved that I'm aware of on the market. Dehydrated, most of them are preserved in a vacuum at low temperature. And the FDA has them labeled as wound covering. And there is a difference between wound covering and wound healing as we get into the presentation. These can be kept at room temperature, and they have to be, in a sense, rehydrated once they're taken out of the package. So you remove the disc carefully. You have to identify, in most of the cases, which side is up and down. Some of them have a watermark, and one of them has the IOP so that you can see it and know that it's which side needs to face the cornea and which side needs to face the eyelid. You put a few drops of sterile saline to rehydrate the membrane, and then you could cover it with a bandage contact lens. They're a little cheaper in cost, and you're going to see why here. You're going to see when you get the cryopreserved, and we heard a little bit about pentraxin 3, and I'll cover that in that heavy chain hyaluronic acid, which is extremely important in the wound healing. They can be stored on the shelf. They're not freeze dried. And you could use, and this is an advantage, if the patient is allergic to Cipro or amphotericin B, and that's what the cryopreserve is stored in, then this might be an option to go to a dehydrated if they have an anaphylaxis to amphotericin B, which is a fungal agent, right, or an antifungal agent, and Cipro, which is a fluoroquinolone antibiotic. The dehydrated require a few extra tools: a lid speculum, a Wexel sponge, a bandage contact lens when doing the procedure. Switching over now to cryopreserve. So we just talked about, in a sense, wound healing. Now we're going to talk about, wound covering. Dehydrated is wound covering. Cryopreserved is wound healing. And you can see here that, there's single sheets, and you could use this for the less serious, which is bacterial infection, keratitis, and then the double membrane, maybe in something like a very severe corneal ulcer, Stevens-Johnson's, or an alkaline burn. The other thing that you need to remember is the hotter the eye, the quicker this membrane will dissolve. So I've had to use a single membrane, or I've used a single membrane on these patients that are filamentary keratitis, or an early to moderate dry eye where they're not responding to the therapy the way they should be. And you put a membrane on, the eye's not hot at all, and you might see them back in a week, and there's still a membrane on there. Now, if you have an infectious corneal ulcer, they might burn through it in 2 or 3 days because the eyes are really, really hot. So the next question I usually get is, what's the perfect time that could be on there? And the analogy I like to use is like bubble gum. You put a piece of bubble gum in your mouth, you start chewing on it, and it's got that great spearmint flavor. And, after about 5 hours, it's kind of gone. You can tell that there's a little bit of flavor there. So 5 days is what you really want that amniotic membrane on there to really download all those cells and create as much regenerative healing. You do kind of get a little bit of a bandage contact lens at day 6 or day 7, but really 3 days minimum. Man, if you can get them to 5 days with it on there, which most patients can because they have severe problems, they'll keep that membrane on there because they want fixed. And like these filamentary keratitis patients, once they see how great their eye feels, they have no problem with it, wearing it for that 5 to 7 days, coming back and doing the other eye, because then they get about 6 to 9 months out of it. So there's a few pearls in there on how to use amniotic membranes. Again, dehydrated, you have to know which side's up, and you have to be real careful when you wet it. It can really curl up pretty quickly. Now, we talked a little bit earlier about these patients, and do the procurers of the placenta, do they chill at the hospital? No, these are all planned C-sections. You can see they're checked for HIV 1 and 2, the hepatitis B through C. They're checked for syphilis. They draw blood 7 days before. They do microbial testing, because you'll get these questions from the patient. You'll get them like, hey, how safe is this? And you'll want to be armed to say, look, they're tested way before, they're tested afterwards. They're tested for microbial. They do blood drawings. These are safe to use. You want to kind of give that patient some assurance that these are, they're not going to get some other disease by placing someone's, I always tease someone's baby or baby boy or baby girl on their eye. So here, coming down to the components, right? The amniotic membranes have proteoglycans and growth factors, but this heavy chain hyaluronic acid and pentraxin 3 suppress T cells, inhibit giant cell formation, and also controls MMP9. And this gets lost in the dehydration process. And there's plenty of literature out there. So I try and teach the audience in these lectures, and when I do live presentations, I try to teach them where the fish, like the fishes, they usually hang out in that little over by that tree. If you want to research something, research heavy chain hyaluronic acid and pentraxin 3, and you'll see how important it is when it comes to wound healing as opposed to wound covering. And that's how the FDA has allowed these two different types of nomenclatures to be out there. So my point is, just make sure you know the difference between cryopreserved and dehydrated. When you're treating the patient, it's the heavy chain hyaluronic acid and pentraxin 3. That's extremely important. Now, the cryopreserved, they're not, in a sense, frozen where they form ice crystals and things get damaged. It's some proprietary way that they're able to use at this very cold minus 80 degrees Celsius, and it retains the heavy chain hyaluronic acid and pentraxin 3. So that's really the key that's out there when you're trying to differentiate, and you're trying to differentiate between wound healing and wound covering. So let me just show you a real quick insertion here. I have a video here that I can launch, and let me hit play. And you'll see here that this is a patient that had just a persistent dry eye. You're going to hear my voice here. The key to here is you want to rinse off that amphotericin B, that glycol, that Cipro, and there's the membrane. I get yelled at every time I show this video because I should be wearing gloves because I'm, in a sense, contaminating it with but I wash my hands well, but I know that's not sometimes enough. Watch, look down, look down, slide it up in there, look up, and pull the lower lid down. And that's as easy it is to insert. Now what I'm doing is trying to get it to center. And it's on the eye. Obviously, we use proparacaine. So the key was to rinse, put some proparacaine in there, and insert it. Remember, it came from a baby. That placenta stretches. That membrane's not going to break. Now, I do this a lot. We call this a tape tarsorrhaphy. You could see some tape here that I'm just double layering. I'm going to have the patient look down. I'm going to place it right over the lid crease. Look down and put it right over that lid crease. What that's going to help with is comfort and helping that to center so that when he blinks, it's not going over that ring and not going over the membrane to erode it. But it still gives them enough so they can put their drops in. Here we go. We're going to remove it, have the patient look up, grab the edge of the ring, and slide it out. And you can see that there was still a little bit of membrane on here. This was just for a terrible dry eye that he was referred in and couldn't get it cleared up. You could see all the SBK. Look, there's the pupil right there. And this is after. The video stopped. And that was after where the cornea was all nice and healed. All three of these videos are on Optometric Education Consultants. We have a YouTube channel. I usually get asked, can I have those videos? Can I rewatch those videos? The answer is yes. If you're into YouTube, just go to the YouTube and search for it. All three videos are uploaded there to rewatch. And there's the insertion. Now, consent form. Let me launch that while I'm here. This is a procedure. This is considered a minor surgery. So I do a consent form for these patients. And a lot of times when I do these presentations, people are like, can you just send me your consent form and so on and so forth. So I'm going to share that for you right now if you want to download it. I believe it says, it says sharing there. And what I have in the practice, it's a should be a Word document that you have there. If not, just email me. I'll send you the Word document. And the reason why I'm doing a Word document is I took off our logos. This is our minor office procedure form. And you can see we have the docs in here, the modifiers, which are 10-day post-ops, which are 0-day post-ops. Right there is the amniotic membrane. We check it. 1 drop proparacaine, twice in the left eye, inserted, did a tarsorrhaphy, Dr. Caldwell, patient signs it, witness, and then I sign it. And that's all you really need to do for a consent form, especially if you're doing minor procedures. And you can see it goes beyond doing amniotic membranes, foreign body removals, epilation, dilation, irrigation, punctal plugs. Really, those are all, as you can see here, 65,000 and 67,000 codes, which are considered minor surgery codes. So there's a consent form. We do them. Every time we bill a 65 or 67,000, we do a consent form. So there it is for your practice. There's the tape tarsorrhaphy. We talked about it. The reimbursement on these are really, really good. You can see I probably did this one in Detroit recently or in Michigan recently, and you could see that it's a 0-day post-op. It used to be a 10-day post-op, and now it's a 0-day. So you could see them back 3 days later and bill a 99,000 code. In Detroit, it's about $1,430. You can see the rest is $1,330. Great reimbursement for the practice. But what do we always do first? It's always about the patient. The patient heals. It's a great procedure. And then the beauty of it is it's just a nice reimbursement for the practice. And that's why I try and buy 5 or 10 of these at a time, because you can get them at a discounted rate, and it helps increase, in a sense, the profits. So a little practice management there about the profits, but really it's all about the patient and getting that scarless healing and that wound healing that we talked about. Contraindications for cryopreserve, the Procara, if they are allergic to Cipro or amphotericin B. You don't make your glaucoma surgeon upset by if they have a great filtering bleb superiorly and putting an amniotic membrane on it and scarring down healing their bleb, especially after they tried and using all maybe mitomycin C. So watch out for patients that have filtering blebs or drainage devices. That would be contraindicated. And maybe someone that has an incomplete blink just because they can't keep the membrane in there. I was just trying to think of all the different maybe contraindications that are out there with amniotic membranes. So why do you want to use them? You want faster reepithelialization. You want to intervene and do and prevent scar formation. You want to improve the rates of corneal clarity. Wound healing is out there versus wound covering. And we talked about all the ocular surface diseases that this could be used for. Now, let me just show you a couple things on the BioD, or one of the dehydrated membranes that's out here. And this is the package insert. So all you have to do is go to the next trade show, hopefully when COVID-19 is all over and we can go back to doing live presentations and have an exhibit hall. If there's someone exhibiting, just go and take out the package insert. And this is the package insert that's inside. And what I want to point out, and I have a few things circled, you can see right through here and right here is what I want to point out on this package insert. And this one right here says, should not be used in the presence of an active infection, right? So you don't want to use a dehydrated in an active infection. So go back to that patient that had maybe that contact lens complication where they had that infectious bacterial ulcer, or that herpes simplex patient that can't get the Zirgan for 24 to 48 hours. Isn't herpes simplex viral keratitis? Isn't that a infectious keratitis? So you don't want to use a dehydrated. It says it right on the package insert. Again, I have no financial interest in any of these companies. What we want to point out here is it should not be used in the presence of an active infection. And then we come down here and it says makes no claims concerning the biological properties of this allograft. which means when they talk about all the healing properties and the pentraxin 3 and the heavy chain hyaluronic acid, really haven't been able to prove much. And when I try to work with the companies and say, can you give me something? Can you show me? The best thing that we can come to, it's better than a bandaged contact lens. There's some type of biologics left behind, but not able to prove things like heavy chain hyaluronic acid and pentraxin 3. So all I want you guys is to be armed if you're going to start using amniotic membranes, which one to reach for, but especially in an infectious keratitis, make sure that you could reach for a cryopreserved, because it is a biological Band-Aid. Right here are the indications. And you can use it to treat infection and superficial corneal disease, suppress the inflammation that's out there. And again, be careful on those drainage devices and filtering tubes, because you don't want to make your glaucoma surgeon mad by scarring them down because you healed that bleb that's out there that they work so hard not to scar down and get that filtering. And then the next question that I usually get is, well, how long are they are good for? Well, here it says right here, when you get it, there'll be an expiration date on it, but typically when you get it, the shelf life is 2 years, right? So if you order something that costs this much and you don't think you're going to use it for 2 years, you're probably really missing a lot of chances in your office from what I showed you before with all the different conditions that are out there. So when I hear the reps talk and they're like, oh, this is the benefit of mine, it's good for 3 or 4 years on the shelf, blah, 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 while cryopreserved is good for 2 years. So you guys, again, you do your analysis and you do what's right for your patients and your practice when it comes to using these membranes. And this was pretty neat. This one came out from a study that was using a cryopreserved, as you can see here, and using corneal nerve regeneration in a self-retained cryopreserver, the Sutureless in the office. And you see these floating around because this is some really cool stuff. You see this in a lot of lectures. Patient comes in, a single Procara or cryopreserved was able to heal this cornea, but they were able to show with an electron microscope that the cornea is regenerated. So really neat out there that the cryopreserved is able to show corneal nerve regeneration. So think about some of your LASIK patients that have severe dry eye. Think about your neurotrophic patients that are out there that you're touching them with a cotton tip without any Preparicade, and they're not even flinching. So that's in the dry eye. How many times have you had someone that comes in, maybe like this patient, and you kind of reach from behind the microscope and you say, you sure you don't feel anything in your eye? You don't have any feeling? That's that, the stain without pain, right? It's that little rhyme, stain without pain. How many times have you seen half an amount of staining and the patients are just, they're in miserable? Well, when you see that stain without pain, start thinking neurotrophic or corneal nerve loss that's out there for these patients. So this would be potentially a good indication when to use a cryopreserved. Now, I did want to shift and talk a little bit about oxyrvate since we were talking about neurotrophic. This has nothing to do with amniotic membranes, but it has to do with neurotrophic keratitis. Oxyrvate was approved by Dompe Pharmaceutical. It's an Italian pharmaceutical company. This is a biologic. My N of this is 3, and it's pretty cool stuff. The patient has to use oxyrvate, so a biologic. They actually use E. coli. They get the DNA sequence, put it into E. coli. It comes out human nerve growth factor on the other side. And then the key is twisting it up to make it look like human growth factor, and that's where all the cost comes from. And they use it, basically, here are the numbers when you see it, every 2 hours, 6 times a day for 8 weeks or 2 months. And they come in individual glass bottles. Biologics are very fragile. The patient has to kind of draw it up in these little pipettes. But when you get someone that is neurotrophic keratitis, it's pretty neat to watch the cornea heal. And again, it's endogenous nerve growth factor that's out there. And you're just making this huge molecule. And that's where the cost comes into play with these biologics. And here's the Oxervate kit. Again, 7 vial adapters, 42 pipettes, the disinfecting wipes out there. And the patient gets it mailed to them every 2 weeks. And then they instill it into their eye. It just takes them a little bit to kind of get used to. You kind of train them in the office, and then they use it. There's that every 2 hours, 6 times a day for 8 weeks. And here's a patient that we were starting already to heal them. And when I started using it, my N of 3 was this year. Now the key to this is the cost. The key to Oxervate is $95,000. So Dompe has set up foundations and so on and so forth. But this isn't a biologic lecture. This isn't have anything to do with amniotic membranes, but it does have to do with neurotrophic keratitis. And since we were talking about that at the beginning and kind of there with this corneal nerves, I also wanted to kind of give you another therapy that's out there for neurotrophic keratitis. So with that being said, that should put us pretty close to our 50 minutes with the way we had our sponsor at the beginning. Let me see if there's any questions in here. If not, if you guys want to go to the chat section, I will just kind of hang out here for a minute. I'll try and think if there's any other if you want to enter questions in there, I'll be more than happy to answer them. And if not, then we'll wrap up. I think I pretty much covered everything. I'm scrolling and taking a look. Not getting the polling answers. Yeah, that's why I didn't do the rest of them. I'm not sure where the glitch was with that. So, all right, let me make sure the questions are on. Enable chat. I think maybe. Do you need a prior authorization from insurances to use Procara? The answer is no, from at least the insurances in Western Central Pennsylvania that I use. However, what I do for the patient is I will work with my billing department. The nice thing about having a 5 OD practice is I have a full-time biller. And I walk in to see Leslie and I say, can you just do me a favor? So-and-so has this condition. She already knows the procedure code. I give her the diagnostic code and she'll call the insurance company because a lot of time they'll have a big deductible and this will just all be applied to the deductible. So there's no really prior authorization out there for that, Melissa, but there is a little process. I don't judge the book by the cover. I've had people pay full price for this, apply it. I tell them what their condition is. I tell them what their chances of recovery are, and I tell them about this therapy and let them decide how they want to spend their money. A lot of times they can use a health savings account, but you do not need a prior auth, but I do find out what the cost is going to be. Normal freezer for storage. Well, for OSHA reasons, you don't want to use the staff freezer upstairs, in the kitchen. So I know at one point, whenever I bought my first one, BioTissue, if you bought 5, I think, gave you the freezer. If not, if they don't do that anymore, I'm not sure. I'm not sure if I remember hearing it at the beginning, but you just get a regular old, like you had a refrigerator in college size, one of them little cube ones, but they come in a freezer, and just use that to store them for the safety of the OSHA regulations that's out there. Okay, thank you. It says great lecture. Thank you for that nice comment. So in most cases, before using, I need to debride the cornea. That would only be for recurrent corneal erosion. If someone's coming in for dry eye, nothing to debride or debride, tomato, infectious keratitis, anything else out there, no reason to debride a cornea unless it's recurrent corneal erosion. I like whenever they tear open to take off any remaining loose. If it's an epithelial basement membrane type of disease, then it usually goes limbus to limbus. So that's the only time that I will do that, debride the cornea. Have you heard of using lyophilized amniotic membrane? Oh, yes, I've heard that. It's kind of amniotic membrane kind of chewed up into a bottle. I don't have any experience. So have I heard of it? The answer is yes, but I don't have any experience with it. How much is a Procara? I think it all depends on how many that you buy. And I think you can get them probably, I think $700-ish, maybe a little bit lower if you buy more. But talk to your reps about that. That's out there. Your local reps that's out there. Would you use dehydrated membrane on a filtering bleb patient? I would not use and I wouldn't use any amniotic membrane because they both have healing ability. I wouldn't use a dehydrated or a cryopreserve because we definitely don't want to do that. So, molecular biology of this as well presented. Oh, thank you, Tim. Okay, Donna. When and how, and this is Edmund, when and how you see the replay? Oh, the replay will be set in about 14 hours. And then that eventually will expire, guys, and then it will be on the YouTube channel for you to be able to watch. Approximate cost, we talked about that. How much is Procara? And I see a nice comments rolling in. It's always my pleasure, guys, to try and teach and make everyone better at clinic. I'm going to wrap it up there. Thank you, guys, for attending. And regarding credit, if you sent in an OE tracker number, Vanessa will get things uploaded within a day or two. I know she's traveling. She'll also send you a letter via email. She usually takes about a week to generate all that. So within a week, you'll get an email letter of certificate that you were here. If you supplied us your OE tracker number, then that will get uploaded to Arbo. I think that puts us at perfect timing to meet all the requirements. Thanks, everyone, and looking forward to seeing you at a live conference or at another webinar. Take care now. Bye-bye.